Hey, welcome everybody to our April Lunch and Learn series. I'm Leslie Hammond. I work with the Home Care Alliance of Massachusetts, and we offer a once a month free webinar on business development right around lunchtime, middle of the month. And today we're going to work on some home care safety issues. I know you're all aware of some scary things and that happened last fall in Boston or 2 years ago in Connecticut, and it's so important for us to keep our caregivers safe. And today Ryan at OK Alone is going to give us a little preview of what they've got going on over there. And we will leave time at the end for questions and comments. So feel free to put it in the chat as you think of it, and we'll get to them at the end. All right. All right. Take it away, Ryan.
Awesome. Thank you, Leslie. Yeah, appreciate you all joining during your lunch breaks. But my name's Ryan Obsuszt. I'm a VP of Sales here at OK Alone. I've been working in the worker safety industry for the last 5 years now. And I would say a heavy amount of the use cases that I've seen over the years is in the healthcare sector, specifically home health and hospice care, where you don't really know the environment you're going into. Sometimes, whether that's the caregiver or specifically the families that are in those homes, and just other people inside the home. So what we do is we try to, reduce a lot of those risks out in the workforce. Home care is delivered in environments we don't typically control. But safety is something that we can control, and that's exactly why associations like the Home Care Association for Massachusetts are focusing more attention on workforce safety and operational readiness across agencies in the Commonwealth. So, really, thank you for joining us. Home health care is really some of the most important work in our communities, and it's also some of the most exposed. So, staff often work alone, they're moving fast-paced environments and the operating environments we don't control. So today is really about practical field-ready protocols you can implement immediately to reduce incidents and improve response readiness and really just make sure that safety is a consistent workflow as you continue to build out what workforce safety looks like for you all. So home care is a high trust work in a low control environment. So you're asking staff to work into situations where conditions change visit to visit and sometimes hour by hour. So unlike in the hospital or facility setting, environments isn't changed around care delivery. Staff are entering private homes, neighborhoods they might not know very well, potentially situations where other individuals may be present in those situations. And then really on top of that, it's the time pressure. Schedules are tight, visits are back to back, teams are often working alone, with really very limited real-time supervision once they enter that person's home. So the combination of unpredictable environments, those time pressures, and limited visibility once someone is in the field, it's what makes safety and home care fundamentally different. And that's why safety can't rely on an informal process or good intentions alone. It needs structure. And that's what we'll talk through here in a second. I did want to, share some stats here. So really just to understand why we need practical protocols, we have to be honest about what the current risk landscape is. So workplace violence and injury in healthcare isn't an occasional problem, it's a structural hazard. So according to the US Bureau of Labor Statistics, healthcare and social assistance workers accounted for 72.8% of all non-fatal workplace violence cases requiring days away from work. And this study was done in 2021, 2022. And that's almost 42,000 cases over a 2-year period, which is far higher than any sector in the US. And then when you look at specifically in Massachusetts, the scale is really hard to ignore. Every 36 minutes, a worker in Massachusetts hospital experiences an act of violence or threat. Nurses and healthcare workers experience violent incidents at least 5 times more often than the average private sector worker. And what we see is that tells us really two things, is violence and threats and intentional injury in healthcare aren't rare. And that healthcare workers are disproportionately affected compared to other industries, that they might have people who work alone. So, This is relevant for home care where workers are isolated, unobserved, and they really face different environments potentially where risk can be exposed to them. So I thought those are some interesting stats there that we saw with the Bureau. Um, And even organizations that care deeply about safety still see the same breakdown point. So policies exist, but execution varies visit by visit. Escalation is expected, but ownership isn't always clear in the moment. Incidents may be reported, but patterns aren't identified early enough to prevent the next one. So what we see again and again isn't, that lack of care. It's just a lack of structure. So when safety relies on memory and personal judgment, someone remembering to follow up on a caregiver potentially, consistency tends to slip in those situations. And in an environment that changes visit by visit, that inconsistency could potentially increase exposure to your team. So, and then just to kind of give you an idea of what that looks like in the field. So here's what a breakdown looks like day to day. One, you call your supervisor if something feels wrong, but the supervisors are busy and the worker hesitates. Early warning signs get missed because there isn't a clear structure trigger. So two, report incidents at the end of the shift. Minor events don't get logged, and when small events aren't captured, you lose that chance to see patterns before they become more serious. And then three, escalate if needed. But if needed, it's really subjective. So when there's no shared threshold, people pause to decide what do we do in these certain situations, and delay in response are exactly what we're trying to prevent. So the goal today is to move from good intentions and scattered steps into something that's consistent. A safety workflow is really teams that can run it in a real world situation. And if safety can't rely on memory or an informal escalation, the next question is, what are regulators expecting organizations to do? And that's what I'm going to touch on next, is that there are some federal and local state expectations when it comes to worker safety. And you may or may not be aware, so apologies if a lot of this is repetitive for you all. But um, at a federal level, workplace violence in healthcare is not considered a rare or unexpected event. It is recognized as a serious occupational hazard. So OSHA, which is Occupational Safety and Health Administration, explicitly identifies workplace violence as a hazard in healthcare and social service settings. And OSHA expects employers to assess risk, implement preventive measures, train staff, and maintain reporting and corrective processes. Even though there isn't yet like specific federal workplace violence standards in healthcare, some different states are pushing out things at a state by state level. But they do enforce the general duty clause. So the clause requires employers to provide a workplace free from recognized hazards that are likely to cause harm. So given the data that we discussed earlier, including, in healthcare and social assistance, it accounted for 72.8% of non-fatal workplace violence cases. So it's really hard to argue that, this hazard is not recognized. So that general duty clause is important at a federal level, but there is some stuff coming out at a state level that you may have heard of. So from that federal standpoint, the expectation is really clear. If a risk is known and foreseeable, it must be addressed systematically, and we're starting to see that expectations reflecting more clearly at that state level. So here in Massachusetts, lawmakers have advanced legislation requiring healthcare employers to implement workplace violence prevention programs. And these programs include risk assessments, um, written prevention plans, staff training, and stronger reporting processes. They've also established stronger legal protections for healthcare workers experiencing violence on the job. So while much of this legislation focuses on healthcare facilities, we believe that the direction is clear. Policymakers are increasingly expecting organizations to take a structured approach to prevent violence and protecting your staff. And responsibility of organizations don't usually wait for legislation to force change. they build that structure in early, which brings us to the operational question. If safety must be structured, what does the structure actually look like? So we'll touch on that of how we can address this as there's more momentum when it comes to workplace safety in the state. So we've looked at the risk. We've also looked at where processes break down, and we've looked at what regulators are expecting. And then the common thread is that safety cannot depend on individual memory or judgment under pressure. It has to be structured. So safety becomes reliable when it's a workflow. So defined by or before the visit even begins. So risk is assessed intentionally, not reactively. Um, Clear during the visit. So staff know exactly what to expect of them and what supports look like. Automatic when something goes wrong. So escalation doesn't rely on hesitation or interpretation, and measured, reviewed afterwards. So organizations learn and improve instead of repeating patterns. So when safety is built into a workflow for the overall organization, it stops being reactive and just becomes an operational procedure for you all. And really, what does that structure look like? So, um, what the structure looks like in home care settings is we found it breaks down into five practical components. So first is doing pre-visit risk assessments. So before someone walks into a home, risk should be understood and categorized. And then second, a structured check-in routine. So not optional check-ins, but defined cadence based on the risks. Third is that clear escalation path. So everyone knows who owns the response, what triggers it, and what happens next. Fourth is really the incident logging and reviewing. So not just reporting events, but using them to adjust future risks that may occur. And then fifth is just adoption and accountability. Safety only works when roles are clear and expectations are reinforced, and performance is really visible. So this isn't theoretical. It's repeatable, and agencies can implement this immediately, whether it's manually or supported by a system. So if we jump into that first step that we talked about, it's um, every reliable safety workflow starts before the visit begins. So in home care specifically, once someone walks through the door, your ability to influence the environment is really limited. So the preparation stage really matters. So that pre-visit risk assessment isn't about assuming the worst. It's about recognizing the environments vary and risk is situational. This means identifying environmental risks ahead of time, reviewing patient history, behavioral indicators, flagging known safety concerns clearly and visibly, and defining visit-specific safety controls before someone is alone in the field. So when this step is skipped or it's informal, everything downstream becomes more reactive. And when you have that structure, everything downstream becomes more predictable. And then, really, when we talk about risk assessments, we're not talking about vague impressions. We're talking about structured evaluation. So, first is the environment. You have to consider the neighborhoods that they're working in, potentially the building layout of where they're working, entry and exit routes, known hazards, whether that's animals, unsecured conditions, previous incidents at that address. Yeah, I've heard over the years, even with stray dogs, like I've heard of caregivers being bit by stray dogs when they walk into a home. That's usually not, a known hazard when you're working in this field, but that is considered a hazard out in the field. So, and then second is the patient and household context. Is there a documented history of aggression, mental health volatility, substance misuse concerns? Are other individuals present who may change that dynamic? I've seen that really, over the years that it's usually not the patient that you're treating, it's other individuals that are in those homes that become a risk or a hazard potentially. So it's something to consider. And a lot of that's not documented when you're doing these home visits. And third is situational factors. Is this a first visit? Are you doing this during after hours? Has there been a recent escalation in behavior? This doesn't require complicated scoring tools, but it does require some level of consistency. So, even if a nurse or an aide is left to assess risk informally in their own way, you lose that visibility across the agency. So, what good looks like in practice? What does a strong pre-visit risk process really look like? And I think it starts with a documented risk score before your first visit. So even if that score is simple, clear safety notes are attached to the client record so that information doesn't live in someone's memory. And then those visits are categorized, whether they're standard, elevated, or high risk situation. And so that's really able to monitor those expectations accordingly, and you can adjust as you're doing these visits. And then safety controls are defined in advance. So this might mean shorter check-in intervals, supervisor awareness before entry, or defined escalation thresholds. And critically, risk status is reviewed after any incident or any meaningful change, whether that's in their behavior, the environment, or the visit conditions, because risk isn't really static. It's a patient situation can change, household dynamics can change on a daily or weekly visit. Um, and then visit timings can also change. So the safety plan should change with it. And it really sets the tone for the rest of the workflow when you're really assessing what the risks are. And then that second step, so it's and I think this is really important, is having that structured check-in routine. So once risk is assessed, the next question is how do we maintain visibility during the visit? This is where structured check-ins really matter. So check-ins should be scheduled. It's not optional. Frequency should reflect the level of risk identified in that first step. So it could be environmental risk potentially. And then the system shouldn't rely on your memory. So when check-ins depend on someone remembering to call or text, consistency tends to really vary. So under those time pressures and people prioritizing clinical care as they should, clinical care is the most important part. Um, Administrative steps get really pushed aside in these instances. So a structured check-in routine removes that variability, but it also sets a clear expectation that when you confirm safety, missed check-ins must trigger some sort of action. So whether that's a call or a text, it's having some sort of welfare check on the individual when they're providing care out in the field and in these different environments. So, what risk-based check-in cadence really looks like. So, in check-ins should not be a one size fits all. They should be proportional to the risks that they face. For a standard risk visit, this might mean routine time check-ins, confirmation at the end of the visit potentially. And then for elevated risk visits, intervals should be shortened. So supervisors may be aware before entry and monitoring becomes more active. And then for higher risk visits, monitoring becomes structured and more frequent. But frequency alone isn't enough for higher risk situations. So staff should also input detailed information before the visit begins. So things like known behavioral concerns, precise location details, maybe even the length of the visit that they're expecting to be there. And the way is if an alert is triggered, the person receives it has context. So they understand what they're responding to, and the context really improves the quality. So the goal is not just faster alerts, it's better informed responses, and the proportional approach protects staff without overwhelming teams. So it avoids unnecessary alerts while ensuring that higher risk situations or scenarios that could occur, they receive the attention that they need. And then, let me make this a little bit more practical. So if we're thinking about, let's say, a nurse, if we're using a nurse as an example, and scheduled for a first visit, the patient is recently discharged because of a behavioral health episode potentially. The pre-visit assessment flags that elevated risk before they even arrive at the home. So instead of treating that like a standard visit, monitoring frequency shortens supervisor awareness, and it's logged before entry. So the nurse's input notes about those behavioral triggers, and then really the the household dynamics that we kind of talked through. And then midway through the visit, a check-in is missed. And this could be because the frequency was proportional and the information was recorded in advance. The monitor reviewing the alert isn't starting from zero. They know what the elevated risk was of the visit, potentially the behavioral context of the patient that they're treating, and then the escalation begins immediately and appropriately. So that's really the difference between informal safety and having a structured safety workflow. So the real test of a check-in system is not, everything goes smoothly. It's what happens when something is really missed. So a missed check-in should trigger an automated alert to a designated monitor. That could be a direct supervisor even. And that alert should prompt immediate review of the last known status or location, and escalation should begin without hesitation. So the key word here is automatic. If someone has to notice the absence manually, delays creep in. If someone has to decide whether to act, there's really clear triggers that reduces that hesitation. You know that if something happens to someone out in the field and they miss those check-ins, you have a procedure in place to confidently, address, what may have happened. And then that third step, so defined escalation paths. So a structured check-in routine only works if escalation is equally structured. So every alert must have a clear owner, not a shared understanding, not a general, expectation, a real named role. So those escalation timelines must be defined in advance. And if a check-in is missed, how long before the first contact is attempt. If there's no response, how quickly does it move to that next level? So it's about having true levels of escalation. If a supervisor isn't, checking in on their staff, what is that next level of escalation to maybe their direct supervisor? And most importantly, staff in the field should know exactly what happens next. When people understand what the process is for working alone, they're really more likely to use it confidently. And then that ambiguity really starts to kick in and it creates that level of hesitation, if something, happens to someone out in the field. And I kind of touched on this, but having a clear escalation ladder. So a practical escalation ladder is simple and predictable. So first is attempt direct contact with the worker. Second, notify the supervisor or an on-call lead potentially. Third, contact the designated emergency contact if required. And then fourth, escalate to emergency services, if those thresholds are met. So the sequence itself, it's really not complicated, but what matters is that it's documented, it's rehearsed, and it's really consistent across all teams. And then when escalations depend on, what we usually do, response times usually vary. And then when those escalations follow a defined ladder, it becomes more procedural and you're really just getting faster response times and, it's just creating clarity across the organization. We know exactly how to handle a potential incident as they come up. So that response readiness is really what matters. It's that time to response. And it's the difference between having a plan and being able to execute it. So who is monitoring during each shift? Is that role explicit? Does that fall on the person's direct supervisor? Who's responsible of making sure the staff, get home safely in essence? And then what is the maximum acceptable response time after a missed check-in? Is there a backup defined, primary monitor if they're not available? And then are all those actions logged? These are questions that really sound simple, but they aren't answered in advance, and that gets the answers in the moment. So in decisions made under stress, it's really optimal. So readiness is built before it's needed. So these are just some things to consider as, you're building out that readiness plan. And then the fourth step, which is incident logging and review. So step four moves us from reaction to learning. every safety event should be logged, and that includes near misses. Near misses are early warning indicators, potentially. And then they tell you where escalations almost became necessary, and that's where patterns may be formed. Logging should be simple and consistent, and then if reporting feels burdensome, underreported increases, and that also hides risks. So understanding some of those environmental risks out in the field is important, and it kind of helps you create an action plan as you're deciding where individuals should be providing services, and just really having that high level review. Turning incidents into improvements. So the purpose of logging isn't documentation for its own sake. It's a pattern recognition and future planning. So are repeat issues occurring at specific addresses? Are certain timeframes associated with higher escalation rates? Are near misses signaling that a visit is being underclassified as a standard risk? So those near misses are especially important. They're really those early warning indicators, and they tell you where something almost required escalation and where the risk may be increasing. So that incident data must feel, directly back into those risk assessments. And if a visit is generated an alert or a near miss, the next visit shouldn't be treated the same way. So the monitors cadence may need to really change. So the risk category may change, supervisors' awareness may need to increase. And this is really how safety becomes adaptive. So when organizations review incidents, whether that's they do that monthly or quarterly, and it adjusts protocols accordingly. So safety becomes a continuous improvement process and not just incident response systems, and that's when you start reducing those repeat exposures instead of reacting to it. And then, the fifth step, so the last step in the procedure is having that level of adoption and accountability. So everything we've discussed so far around risk assessments, having, structured check-ins, levels of escalation, logging or reporting, it only works if it's adopted consistently. And adoption doesn't happen by accident. You need buy-in from your staff to protect them. So safety must be owned. It's not really assumed. And every level of an organization should know what the responsibility is. So leadership, sets the standards, supervisors reinforce it, and then the field staff follow that in confidence. So training should build habits, not just awareness. And then those policy reviews don't change behavior, repetition, reinforcement, expectations. We just want to make sure that there's buy-in across the organization so that you have a protocol to address certain situations if something arises, and that there's confidence in the field staff that, they're able to get help in case something were to happen. And then, what gets measured also gets reinforced. So if safety isn't visible, measurable, it quietly slides down the priority list. So start simple. What percentage of visits have potentially completed check-ins? What is the average response time to a missed check-in? How frequently are incidents and near misses being reported? Are risk assessments being completed after an incident? How often do supervisors review safety performance within their team? So there aren't, compliance metrics. They're really cultural indicators. And when leaders look at the numbers regularly, that sends a clear signal. Safety is not reactive, it's operational. And then when safety becomes operational, that consistency follows. So that's why that five-step process, I think, is vital. Is going through that and understanding what are the different levels of risk that you might face, and then how can we structurally address safety in these procedures. So. Now, I've covered a ton, and apologies if I've been rambling for the last however long. But, we've covered a lot of ground, so none of this works unless it's actually applied. And really, the next step is simple, even if it requires discipline. So start by auditing your current safety process honestly, not what's written in policy, but what actually happens out in the field. So identify where breakdowns are predictable, where does escalation depend on interpretation, where does monitoring rely on memory, and then formalizing your five-step workflow. So write it clearly, define it clearly, and make it visible. So assign ownership at each stage. Safety only improves when the responsibility is explicit. And then reviewing your safety performance monthly, looking at patterns, adjusting categories, and it's just reinforcing that expectation. And then finally, treat safety as a priority. So it's not something that's delegated entirely to operations. It's not something that revisits only after an incident. Organizations that really reduce those exposures over time are the ones that treat safety as a part of how they lead. And then home care will always be a high trust work in a low control environment. And I don't believe that'll change. But what can change is how intentionally we structure safety around it. Like I mentioned, in the home care setting, I've heard of a ton of stories where, nurses or caregivers are going into people's homes and they sometimes don't know the entire situation or environment, that they're getting into. So these protocols, these workflows will really help create a level of confidence that they're going to want to provide care out in the field and ultimately their safety so that they get home. And then
We get
obviously,
unmute. Yeah, we get um it's a small group. Let's have a conversation.
yeah, I know I've gone through a ton, but
Yeah,
yeah, any questions from the crew so far? Or we're getting towards the end?
yeah. What do you guys think about what are you doing right now? What things are in place where you're at? Maybe what's working well? Where could you use assistance? If you don't have a microphone, you can, or you're not interested, you can type it into the chat.
Yeah, you can always answer
Yeah,
questions in the chat.
yeah.
I actually can't see the chat, so
Oh, you
apologies.
can't. If you want to yeah, you can stop sharing if you want, but nobody has mentioned anything. But
Okay,
Jane,
that's fine.
Peter, Annalise, Christine, Donna, Yvonne, Megan, Sarah, any thoughts as we wrap up our time together?
Nothing.
Well, oh yeah, Yvonne, go ahead.
No, I said nothing for me.
Oh, nothing for you. Okay, great. Uh, well,
All
Ryan, do you
good.
want to talk a little bit about what you guys are doing in the space and what's new and along?
Yeah, yeah. So, really, everything that I've kind of gone through today, it can be implemented manually, but that's really what we do for a living at OK Loan. So we're trying to create levels of automation. So OK Loan is designed for that operational five-step that we covered. So the structured check-ins become scheduled and trackable in our platform, and it's not dependent on memory. Those missed check-ins are triggered automatically alerts, and then it's gone through a level of defined escalation pathways. So it reduces that hesitation. We know which supervisors are getting notified in certain situations if something happens to a nurse or a caregiver out in the field. And then those supervisors then can gain real-time visibility because we're providing the location of where these incidents occur out in the field in case something were to happen. And then that really just improves that response readiness. And like I mentioned, everything is logged in our system, so incidents become centralized and accessible, and that makes pattern review much easier. And then monitoring can be adjusted based on risk categories, so oversight remains proportional. And the goal isn't, having a complex solution. It's really just consistency, and it should just be a way that creates a level of ease of mind for the worker that if something happens out in the field, they have a way to notify a manager, a supervisor, internal staff, external, that they're in need of assistance at the end of the day. So we have impact detection if someone detects a fall or slip, if someone's unconscious for 5, 10, 15 minutes. we can send alerts through automatically. And then you can see here, there's a help button or an SOS button in essence, that at any point they can trigger that alert and it's going to get sent through that level of triage and escalation to the correct people. So, yeah, we're just trying to improve safety across the industry. And, I think this automation helps because it doesn't rely on supervisors having to constantly check in with their teams and the system's already doing that for you.
So there is a question in the chat from Donna, and it's a good one. Does it integrate into CRMs, Access Care, or WellSky, or any of the EVV models?
Good question. So and that's also part of the reason we're here is just to understand like where the needs are in the industry. So we do have an open API, so we do integrate into, HRIS systems like Workday. We do integrate into fleet management systems, which I know you said you're doing something with fleet management next month, which is funny. So, I think a big thing for us is, those EVV systems, EMR systems, those are things that we can integrate into where this could just be a workflow into what they're already doing. Maybe potentially having a panic button as they're doing clinical documentation in other tools. So there's a ton of flexibility in the system, and yeah, we can integrate into all those that you mentioned.
Currently, are you in Access Care or WellSky?
We currently are not,
Okay,
no, but we have the ability to integrate with them.
good question.
Yeah, good question.
Are you guys integratable with can time?
Can time. Yeah. So similar asset there. We have the ability to. We haven't had customers that we work with directly that have integrated with can time, but we can based on our API. Because really the system itself, it's all centered around location data when an incident occurs, and we can feed all the information into can time or WellSky or any of those platforms. So there's not a ton of legwork from their side as well. In an ideal world, what would that look like for you? If you mind sharing, like if this looked like something that you would want to roll out to your staff as a safety measure, what would that look like in your current process that you're doing with can time?
Well, I'm just imagining it similar to kind of like during COVID's pre-screenings that you would do like a questionnaire right before punching in or as you punch in, um,
Yeah.
kind of like going over whatever amount of questions to verify the safety of the household.
Okay. Interesting. Yeah. So like a pre-screening assessment that appears
Hmm.
yeah. Okay. That's a good point. Um, Have you, as far as any sort of assessments when it comes to safety, are you doing anything externally? I know like a system like that doesn't do that.
I mean,
But do
we
you have any?
do like home assessments when we go out to do
Oh,
the recertifications and whatnot. That those usually are incorporated into our regular assessments. Um,
okay.
but that is kind of part of like even if there is any type of like safety risks here, we would
Yeah.
have to do like a safety assessment every single time we get something reported. Go out there and do a home evaluation.
Oh, okay. Interesting. And are you doing those frequently? Like, are those updated potentially?
Those are actually done every 60 days at least for our patients. And if there's
Oh,
any
fantastic.
outlier or like if something occurs within the environment, then yes, we do have to go out there more frequently.
More frequently to check on it. Okay, interesting. I appreciate you sharing. And yeah, I think, that workflow that I walked through, I think that, it just helps kind of structure things. So yeah, 60 days is great. And obviously if there are changes in the environments and the homes, like being able to adjust on the fly is vital. So that's great that you're doing that. Um, awesome. Yeah, any other questions?
Thank you, guys.
Awesome.
I will send a recording of this in the notes to everybody, and do take a look at our calendar. We have a lot of great things coming up. We have a big conference, our annual conference, which are you coming, Ryan? I think you're on the list,
Yes.
right? To
Yes.
Be there. I
yeah,
already registered.
already registered. Excellent, excellent. So that's in Manchester, New Hampshire, May 4, 5, and 6. and Ryan will be there to answer more questions and
Yep.
connect with all of you. I'm pretty excited. I just made the bingo cards this morning, sent over to the printers. So there's a bingo square for client safety, or I think might just be safety product. So check out Jordan and Ryan at their booth and get your bingo card stamped. All right. Thanks a lot, guys.
Awesome. Yeah, thank you all for joining.
Thank you. Have a good day.
Thank you again.